Hi, everyone. Thanks so much for joining us today. I have to throw out the disclaimer and apology in advance. My 2-year-old is immediately above me with his grandfather, and it's right before nap time. So if he is jumping around and screaming, it's not because there's weird stuff going on here, at least nothing that I'm contributing to. So the talk today is clinical work with patients of color amidst national race-related events. And let's see. So here's the agenda. So I'm going to start by talking about what racism is, talk about racism at the local level in the Richmond area, talk about racism's effects on access to resources, particularly panning back to kind of a national level. And we'll talk about some of the high profile race-related events that we've seen in the news. And then we'll talk about some tangible skills for addressing national race-related events with patients and creating culturally supportive clinical relationships. So, a lot of people use this term racism without really kind of knowing fully what it means or sort of thinking about it with regard to various kind of lay definitions. But to understand what racism is, you also, I think, first have to understand what race and ethnicity is. So maybe we can start there. So race is seen as more of a biological construct. So it's meant to describe or denote physical differences. These are things like skin tone, hair texture, eye shape, eye color, ears, nose shape, etc. And there are a lot of different theories for how many races there are, but at least in the United States, the primary races that people traditionally identify are Black, white, and Asian. And I realize that that's incredibly minimizing and inaccurate, but I mean, race is really a social construction, just like ethnicity is. So ethnicity, conversely, has to do with cultural identity that's tied to things like geographic region, language, food, heritage, values, belief systems. And then some of the terms that we use in the United States are African American, European American, Asian American, or Latinx. Now, thinking about racism, a lot of times images come to people's minds of things like job discrimination, or the 1950s in the US where people of color would drink from different water fountains relative to white people. Or people think of far right rallies, KKK rallies, Confederate flags. And yes, those are all clearly examples of racism, but racism is much broader than that and much more nuanced than that. So the first definition, this is the one that comes directly from the dictionary. So this is prejudice, discrimination, or antagonism directed against someone of a different race or ethnicity based on the belief that one's own race is superior. So there's very much a kind of interpersonal component to it. One person engages against racism against another person based on that notion that their own race is superior. But in psychology or sociology or my world, we define racism as a system of advantage based on race or ethnicity. So there's much more kind of wider systems level conceptualization. It's not just about differential treatment from one person to another. There's a way in which a system of advantage can become embedded across multiple social systems. So here are some different levels. So you have individual racism, and this is really that dictionary definition. I wish the dictionary definition were more nuanced, but it really restricts the conceptualization of racism to this individual level, right? So prejudgment, bias, discrimination by an individual based on race. And we can think about it in larger terms, things like institutional racism. So these are policies, practices, procedures that tend to work better for white people in the United States than they do for folks of color, often unintentionally or inadvertently. And then you can think about even in more macro terms with structural racism. So this is where there's a history of current reality, a history and current reality of institutional racism across all institutions, combining sort of synergistically to create a system that negatively impacts communities of color and also provides an advantage to white individuals in the United States. So let's think about what racism then looks like at the local level. So if those are if that's the way that we're conceptualizing racism, how does it play out in the context of our Richmond area and the surrounding metro region? Let's think about our sort of unique structure of Richmond. I mean, obviously we have, a downtown area. We have, we're the capital of Virginia. We're also the capital of the Confederacy. So there's this kind of history that's there. And we have, I think, a lot of similar things that other cities of the same size, particularly in the South, have. We have pockets of poverty. We have segregation that exists in various systems. But there's also something very unique about Richmond beyond what you're going to see in a lot of other either southern cities or capitals of states or Commonwealth. So even just thinking about Richmond itself, I mean, you can look at a map of Richmond and there are probably images or ideas that come into your head about some of those different areas, right? Like if I point to a particular area, you probably know the type of people who live there or sort of the modal person or kind of what the communities are, right? I mean, if you go into the east end of Richmond over here on the right, you know that there's the court system or the public housing system. And then as you get closer to the river, you know that there are more renovated houses. Houses are more expensive as you get closer. People know about the Fan District, a lot of kind of renovated and nice row homes. You go out to the West End, this is where like the really wealthy people of Richmond live. And apparently the further along the James River you go, the more kind of Bill Gates rich you get. People know that sort of the southern part of Richmond has a lot of the Latinx community, particularly the Midlothian region, and also sort of the near West End on the other side of kind of the closest part of the West End. So, I mean, there really is some kind of pockets of wealth. There's pockets of poverty. There's pockets of resources or lack thereof that you're going to see throughout the region. And again, that's not necessarily all that different from how society is structured in other metro regions. Now here's the racial and ethnic breakdown of Richmond itself. So about 57% of the Richmond city population is Black or African American, about 38% white, and then kind of a smattering of other groups. Now again, this is just Richmond metro. I mean, this is Richmond city itself. So this doesn't include, the Midlothian kind of southern part of the city where there's a huge Latinx community, where we've actually seen a many-fold increase over the past several decades of the Latinx community to that region. So even though it says 2.57% are Hispanic or Latino of any race, that's not fully accurate if you consider the surrounding areas. So I might ask, kind of this question for you to think about, what's the racial climate like in Richmond? Now, I Googled the terms Richmond and race, and this is one of the first images that came up. And to me, it was so kind of interesting because if anybody recognizes this picture, this is from a couple years ago when the international bike races came through the city. And so there's this kind of interesting dynamic in Richmond of there being this like cool hipster progressive community, this sort of worldly city, but then right in the backdrop there's the Jeb Stuart statue, and of course the Jeb Stuart statue has since come down. Right now the only statue is the Robert E. Lee statue in Monument Avenue, but nonetheless there's this tension between sort of the new RVA Richmond and then the historic Richmond city itself that was once the capital of the Confederacy and is still dealing with that legacy. So there's this dynamic, this tension that I think we're experiencing as a community. And then here's a picture, you probably recognize this picture. This is the Monument 10K. And this is just while I was Googling Richmond and race. And so to me, it's kind of interesting that when you Google Richmond and race, one of the common things that comes up is the Monument 10K. Then to me, it was also ironic, if you look at the faces here, I mean, it's really kind of a sea of white faces. For some reason, this cool, hip event doesn't actually reflect the 57% Black community that you see in Richmond itself. So what we're starting to see is some degree of segregation. And maybe that's a purposeful choice. Maybe this has to do with the resources and the particular demographics of the communities that live in Richmond and what their interests are. But there's a fracturing of communities in Richmond along racial lines. And this becomes even more dramatic when you start to look at some of our institutions. So I might ask, well, what's the school system like in Richmond City? So I used to live in Churchill, and these were the school systems that my house was assigned to. Bellevue Elementary, 2 out of 10. Martin Luther King Jr. Middle School, ranked 1 out of 10. Armstrong High School, ranked 1 out of 10. And of course, these school ratings, I mean, there's so much bias that goes into these things. There's standardized tests, and we know standardized tests are biased. But if we're just kind of looking holistically and making some kind of broad strokes generalization, there's something happening in the East End school system in Richmond that maybe is a little bit concerning. And people in Richmond have talked for a long time about the Richmond City public school system. So you may be aware that this is the dynamic of the city that we live in. And then if I were to ask that question a little bit further, what if I said, is there racially disproportionate access to good school systems in Richmond? Well, let's look at what the racial and ethnic breakdown is for, let's just say, Martin Luther King Middle School. Black, 99%. White, non-Hispanic, 0.7%. Hispanic, 0.6%. Asian Pacific Islander, 0.1%. So there is a profound overrepresentation of Black kids in a 1 out of 10 school system in Richmond. So let me kind of ask the opposite question. What if a family then decides to move to Short Pump, right? So we're just outside of the city system. We're now into the county. What would that be like? Well, here are the ratings of elementary, middle, and high school for the Short Pump area. 10 out of 10, 10 out of 10, 9 out of 10. And then what if I were to ask that same question? Well, is there racially disproportionate access to good school systems in Richmond? And then we'll look at the race and ethnicity of the kids going to the school. White, 80%. Black, non-Hispanic, 4%. Hispanic, 3%. Asian or Pacific Islander, 10%. So what you see in the Richmond area is a profound level of segregation of school systems, far beyond what you actually see in a lot of other cities. And one of the big reasons for that is that in the 1970s, the General Assembly identified several unincorporated cities in Virginia. So Richmond is one of those, and Petersburg is another. So Richmond doesn't actually have the ability to expand into the kind of surrounding county and get the tax base that's in the county because of these laws that were put in place in the 1970s. So what that ends up doing is it restricts the school system from expanding and incorporating any of the county or the county system coming into the city. So you have this urban poverty that's very much concentrated in Richmond City itself. And then you go right into the county, and then all of a sudden houses become a lot more expensive. And the school system, at least according to these metrics, becomes more highly rated. So it's actually a pretty profound discrepancy. It's far more segregation that you see now than you would have even seen in the 1960s, which to me is really incredible. And I'd say, well, what about the organizational environments that we're a part of, right? So here is the Department of Psychology. This is the main administrative psych building. And I've always thought that it's kind of cool that the psychology department where I work is these 5 historic mansions right along West Franklin. And my office is in the one that's right on the corner of let's see, it's Franklin and Laurel, overlooking the park. It's the one that kind of looks like a castle, the big gray one. And so I've always thought that's cool. But I've also had to think, well, wait a minute. When did these things come about? And who are the families that built these houses? And what's the legacy of these houses? And what message does that send to the students that I'm working with and meeting with in my office? Right. So like so all of the houses, most of them still bear the names of the families who owned it. So like White House, mine is Williams House because it was owned by the Williams family. And although a lot of these buildings came about in the late 1800s. So after the end of the Civil War, right? Civil War ended in 1865. A lot of these buildings were built in kind of the golden era of Richmond, sort of the 1890s, which is when a lot of the monuments were put up as well. It was during the Reconstruction time and when a lot of tobacco money was flowing into the city. And so, I think about these buildings, and there's never any enslaved person or currently enslaved person who walked through these halls because they were all built post, Civil War. But nonetheless, there absolutely were formerly enslaved individuals who worked as servants in these buildings, and their children, and that system of segregation that was there. So depending on the floor that a faculty member has their office, they may be in what otherwise was the servants' quarters at that time period. So I have to think about that as a white faculty member sitting in there with often, our diverse student population that we have at VCU. But what message does that send when you've got a white person who has the office in the parlor room of one of these buildings, and then you have students of color coming in to meet with them? Is there sort of an environmental microaggression that sends through just the structure of the environment? And then you also have to think about, particularly, for those of you who are on the med campus, VCU's legacy there. My colleague, Dr. Sean Utzi, who's a faculty member in psychology and also in African American studies, he chairs that department. He created a documentary several years ago called Until the Well Runs Dry: Medicine and the Exploitation of Black Bodies. So about 15 or 20 years ago, VCU was doing some renovations on the med campus, and they found this well. And as they dug deeper into the well, they noticed a whole bunch of bones that were in there. And they looked into it further and further, and then realized that they were all bones of Black individuals from about the same time period. So as they further looked into it, they realized that these were actually Black bodies that were used as cadavers by the Medical College of Virginia for their training program. And so what actually happened is the medical college, and this gentleman right here, would go into the Black graves in the East End, dig up the most kind of recently deceased individuals, steal the bodies, and use them for cadavers. And it's a really stark legacy of the VCU health system. And folks who live in that area still know about that. And I won't say that VCU was too different from some other major medical colleges in the South. Like University of Georgia did exactly the same thing. And it doesn't normalize in any way that process, but it, I think, establishes sort of a network of collusion that occurred from medical colleges during that time period with regard to the exploitation of the local Black community. So again, we have to think of the legacy of our institution. And if you're engaging in clinical work with patients of color amidst that backdrop of the institution of the exploitation of Black communities, that in some ways has to come out and play a role in the context of clinical work.
Hey, Paul, there are a couple items in chat. Do you want to hit them now or do you want to hold on for a little bit?
Sure, yeah, go for it. What are the questions or comments?
Okay, so someone was just mentioning The Organ Thieves, which is a book that recently came out about this exploitation. And then there's a question from a couple slides back. It says, just to be clear, are schools funded by property taxes? My thinking is that if you live in an impoverished neighborhood, schools won't have good funding if the above question is true.
Yes, absolutely. Yeah, that's totally true. I mean, so property taxes, yes, and sales taxes fund as well. So, I mean, you're probably aware if you've gone out to dinner in kind of the Richmond area, the sales tax for dinner is like, for eating out, it's like 13 point something percent. It's super high. And they raised that sales tax recently in part to help kind of fund the school system. So yes, I mean, there are multiple ways that taxes are generated from cities and counties, but yeah, one of those is property taxes.
And then the question is, how does the sales tax get distributed to the schools?
That's a great question. I honestly don't know. I would hope that there's some level of equity in terms of how that distribution occurs, but yeah, I'm honestly not sure. I wish I had a better answer to that.
And that's it for the questions for now. Thank you.
Sorry to punt on that last one. Yeah, unfortunately, I don't know. Okay. So if you're interested in learning a little bit more about some of these issues in Richmond, I would highly recommend this book called Richmond's Unhealed History. And it was written by Benjamin Campbell, who was an Episcopal, he's still alive, an Episcopal minister in the area who moved to Richmond in the early 1970s and has done racial justice work from when he arrived. So I will say that there's a little, because he's an Episcopal minister, there's a little bit of spiritual overtones at the beginning and end of the book, but like 95% of it in the middle is just history about Richmond. And so he traces Richmond from when Christopher Newport first arrived and interacted with Chief Powhatan. And if you've gone to Casa del Barco, which is that Mexican restaurant in Chaco Slip, there's this big cross that comes out of the ground right in front of it. And that's the actual location where Christopher Newport interacted with Chief Powhatan. But he traces the racial fabric and racial history of that, starting from that interaction, because there were profound racial and ethnic overtones of that interaction, all the way up until 2011 when the book was published. So it outlines literally all of the major racial events that have occurred in Richmond, and then describes why we have certain issues that we do today based on race and ethnicity in our city. So it's a super interesting book, maybe about 250 pages, a heavy read, but one that doesn't take too long. So I've benefited a lot from reading that book. All right, so now let's kind of pan back a little bit and think about how racism affects our access to resources, right? So we've been very focused on Richmond, and rightly so, and these larger issues are going to affect Richmond as well, but let's pan back a little bit. So you're probably familiar with some of the differential imprisonment rates based on race or ethnicity. Like white men versus black men is 1 in 17 versus 1 in 3 black men will face imprisonment at some point in their lives. For white women, it's 1 in 111 versus 1 in 18 for black women. And then the numbers for Latino and Latina women are a little bit in the middle between those two. Now let's look at annual income. So, a lot of people are familiar with the general quote that, women make 80 cents on the dollar to, what a man makes. And of course, it changes a little bit depending on the year. But people are not as familiar, in my experience, with racial and ethnic differences in annual family income. So this is all US Census information. When I created this slide, the most recent data published was from 2017. But here you have white families that average $68,000 a year, compared to black families that average 50.4. I'm sorry, compared to Hispanic or Latinx families that average 50.4. And then black families that average just over $40,000 a year. And then you have Asian individuals or Asian families who actually have the highest income rate in the United States on average. So pretty major racial and ethnic differences in annual family income. However, that is absolutely nothing in comparison to the wealth gap that you see in the United States. So family income is one thing, but it's actually wealth that really helps people get through difficult times, because you have to be able to draw on your kind of saved resources in order to be able to get through crises. If problems come up, if your car breaks down. So that's really, I think, what helps buffer people. So in the United States, the average white family has about $110,000 in wealth. So this is when you add up all the savings that somebody has, all the stocks, all the investments, all the equity in their house, everything their car's worth, and then you subtract all their debts. And then for the average Asian family, it's a little over 69,000. Average Hispanic family, over 7. And then for the average black family, just under 5. So, think about the differences there. $110,000 in wealth for the average white family, $5,000 for the average black family. Profound differences, not just in income, but accumulated resources that the family has. So you can ask this question, why are these social problems here in the United States? And it's a very complex question with very complex answers, and there's no sort of single answer. But one of the big ones that I really believe has contributed to it is just the legacy of slavery in the United States. I mean, think about, you look at this graph. This is when slavery first occurred in the United States, 1526. And so slavery was legal from then all the way up until 1865 with the Emancipation Proclamation and the end of the Civil War. Then there was a legal period of segregation for 89 years. It was only until 1954 when segregation based on race and ethnicity was outlawed in the United States. So the relative history of how long the US has been around since relative to a time period where there's no segregation allowed to segregation is incredible. And then if you compare that to when slavery was legal, that's an incredible comparison as well. So we're really not that far out from when these legal systems were in place, differentially affecting racial and ethnic minority communities in the US. All right, so now let's think about, well, what about currently? What's racism like at the national level in terms of some of the dialogues that we've been having as a country? What if we consider some of these racial and ethnic social issues and the backdrops with today's socio-political climate? What if we think about it among these national race-related events that we've seen, particularly over the past 6 months, but honestly, I'd say over the past 10 to 15 years, they've really come to the forefront. So here's some of these events. You'll probably remember some of these faces. So, amidst this backdrop that I was describing, locally here in Richmond, nationally, in terms of how racism has embedded itself into multiple systems that are a part of our lives and to the basic fabric of existence. So again, I'm not necessarily just talking about differential treatment at that individual level, like we were describing with the dictionary definition. I'm talking about how racism as a system of advantage in the United States comes out across all these different systems. And then you think about that in the context of the current socio-political climate and these national race-related events that we've seen. So the question that I might pose to all of you is, what bearing do these national race-related events amidst that backdrop have on the functioning of patients of color that you might work with in a clinical setting? Or maybe participants of color you might work with in a research setting? Or even friends that you have, or even you? What do those things do to people psychologically in terms of mental health? So I guess let me just kind of think about this in the context of clinical work. I know we only have 14 minutes left, but I'm really trying to gear the rest of this presentation to kind of practical things that people who work in clinical environments can do in order to somehow take into account this dynamic. I don't believe that the clinical relationship, at least the ones that most of us work in, are going to fix these problems. So that's a little bit outside the scope of this presentation and this conversation, but I'm just trying to get you to think about what dynamic might emerge and then how you might be able to handle that dynamic constructively. So, things that come to mind for me are, I don't know why that's not coming out. Things like lack of trust in the provider. Like why would a person trust a provider who maybe is of a different racial and ethnic background that has a history of exploitation of that individual? I think about things like engagement and treatment. Why would people who don't feel like their provider understands them or shares their worldview want to continue going back for treatment? Or why would they adhere to medical recommendations that provider might be making? Why would they be of the mindset that they can actually then describe all of the various medical issues that they might personally be experiencing to this provider who they don't fully trust? There can be a lot of dynamics that come up just relationally, particularly in the VCU health system with the patients that we meet with. So what I would ask them is, how can you create culturally supportive clinical relationships, right? Like, let's say that this clinician-patient interaction to some extent mirrors other societal systems of status, power, and access to resources, right? If you think about it, you have a provider who is the person that's resourced typically in this relationship. Obviously, there are often going to be educational differences. There are obviously going to be socioeconomic status differences. And again, this is particularly with the patient population that the VCU med system tends to work with. And I'm talking about the local communities that are here. A lot of times I give talks to the incoming medical resident class about diversity issues. And when I look out at the sea of medical residents, it's rare that I see providers of color in those faces. Yet that's a group, although I would say that Asian and Asian Americans are overrepresented in the context of healthcare providers, but very rarely do I see a representation in those medical classes of the surrounding communities that they're going to be working with. So again, like what does that say with regard to these societal systems of status, power, and access to resources? So there are a lot of potential consequences of that dynamic with people from marginalized social groups, right? Think about separation from the community, or providers, especially if you're coming here for a residency, have you been a part of this community in the past? You're immediately trying to integrate and understand the needs of the community, but you haven't been in the community. Maybe the community doesn't trust you because of these things. Maybe it reinforces other dynamics of power and privilege that are operating. So, there's been some research looking at what happens when clinicians don't adequately address these dynamics effectively. So research has suggested that when patients perceive cultural insensitivity in helping encounters, it reduces the use of those services and erodes confidence in the treatment plan. So, in terms of practical skills, so obviously a lot of this presentation so far has been very sort of macroscopic, systems level, theoretical. And so let me see if I can give you a few very tangible take-home things that you can do differently in the clinical encounter. Now, does anybody recognize this person? So this is Carl Rogers. So Carl Rogers is, or was, he passed away a number of years ago. He's one of the most famous psychologists ever to live. And he created what's called client-centered therapy or humanistic therapy. And he said that when you do psychotherapy with people, there are 3 essential and sufficient ingredients for therapy. That the provider or psychologist has to engage in empathy, genuineness, and unconditional positive regard. And he said, if you have those 3 things, then you establish therapeutic rapport and people can change. So these were the necessary and sufficient elements of psychotherapy that he argued for. So I'd like for you to think about how empathy, genuineness, and unconditional positive regard might be able to come out specifically with regard to things like cultural overtones, and how you might be able to create a more culturally responsive environment in the clinical relationship based on emphasizing some of these 3 essential elements of a good helping relationship. So first thing I'd say is, think about cross-cultural empathy. The difference between sympathy and empathy is that sympathy often has kind of a pity component to it. It's like, oh gosh, I'm so sorry this person has to experience this thing. Versus empathy, where the provider is reflecting back to the patient what they're hearing the patient saying and validating that. So kind of saying back in their own words what they've heard the patient say, and then validating particularly emotional components of that and validating the person's perspective. And when we're talking about this cross-culturally, things might come up in terms of racial and ethnic experiences like isolation, people having felt invalidated based on important aspects of their identity. They might have felt excluded. They might have felt like access to resources were restricted. They might have personally experienced discrimination, either in their lives or environment or from the medical system or from providers. And they may have important cultural values that are there, things like family values or work ethic or spiritual values. So if a provider engages in empathy, reflects back in their own words what they hear the patient saying, and validates particularly anything that might be kind of cultural or touch against kind of cultural undertones, that can be super connecting. And then when clear cultural dynamics come out, there's this technique in therapy called name the taboo. And a lot of times psychologists will do this when things like suicide are coming out. Like the person might say things like, I'm just at the end of my rope. I can't imagine going on like this. And then so what the provider or the psychologist sometimes will do is they'll say things like, it sounds like you're thinking about killing yourself. So they literally go out of their way to name the taboo. And then what that does is it frees up the patient to talk about those things. So similarly, if those dynamics are coming out and you're starting to perceive them, then I suggest that you address them directly and validate them instead of just pretending that they're not there. So you can say things like, you're right, we're from different backgrounds, and I probably don't fully understand all the stressors you're going through. Or why would you trust me? As you've said, people like me have done a really poor job of earning your trust in the past. So you can see how you're kind of going right for that relationally. You're hearing that the dynamic is there, and then you kind of point it out and you validate, like, hey, this is actually a really kind of reasonable thing to bring up, think about, and be concerned about. I feel honored that you're willing to talk to me about this. Thank you. All right, then I think it's also important to engage in cross-cultural genuineness. So how do you let your personality come out in helping encounter? And I think that a lot of patients just don't connect well with sort of a cold, distant professional facade. So a lot of things that I think about is like, how do I let my personal self, Paul, mix with my professional self, Dr. Perrin, so that way I can be more genuine or relatable to people I might be working with. And I think that you should do this in a manner that's congruent for you, because people have all different levels of comfort with regard to how over professional or under professional you might be. And I'm not saying get rid of your professionalism or have poor boundaries. That's not what I'm saying at all. I'm just saying do this in a way that's congruent for you to help you build rapport with your patients, but at the same time still be professional and still enforce the patient-provider boundaries that really are necessary for you to have that good helping relationship. So just be thoughtful about how your genuineness is coming out and how relatable you are to the people that you're working with. And for that third piece of unconditional positive regard, I suggest that you go out of your way to show patients that you legitimately care about them and want what's best for them. Care enough about them and trust them enough to think about and seek out and elicit their thoughts about their presenting issues, right? It can be a lot more empowering when you say, well, you've said these things, what have you tried? What's worked well for you in dealing with this? What hasn't worked well? So that way you're kind of using their own knowledge base and experiences to inform their own health behaviors or whatever the clinical issues that you're working on. A lot of times that empowerment approach and treating them as somebody who has their own volition, thoughts, experience, and expertise can be really helpful and can imply that unconditional positive regard that you have for them and what they have to bring to the medical relationship. And you can also draw on their unique cultural strengths, whether that's sort of individual or collective based on the communities that they're a part of, but things like family and community connections, spirituality. I believe that people who have been through a lot in their life often have had to develop pretty powerful coping skills to be able to handle those things. And so now they're dealing with other issues that may be health related in origin. And so you can help elicit and draw on those coping styles that they've had in the past and that have been successful for them in the past to then handle or deal with this new health issue that's come up. All right, it's a lot for 45 minutes. I saw there was one other question that came up. Logan, do you see one in the chat?
You answered it. It was between empathy and sympathy. So you nailed it. Yeah.
Cool. Great. Anybody else have questions or comments?